Hello and welcome to the Clinical Skills Lecture on the Respiratory System Examination. I am Dr. Joel Vaughan. You all know me by now, and I don't think I have to convince you that breathing is an important function. Therefore, the examination of breathing is particularly important. So as you guys know, I always like to start these topics with a reminder of why this is important. As I always say, we need to remember that no matter whether you're a Christian like I am or Muslim like most of you guys are, God made human beings. Therefore, human beings have immense value. Therefore, taking care of human beings is something that should be done with excellence, with compassion, no matter what your background is, no matter where you are from, what language you speak, what religion you practice, what the color of your skin is. Compassion and excellence are what is required of us. And thankfully God is there to help us. Now, one thing we may differ on theologically, meaning-wise, why does the human body have problems? From a Christian perspective, there's the idea of separation from God caused by the fact that we sin and want to go our own way. Whereas that's not the same in all worldviews. But nonetheless, we can all agree on the human being does have problems. That is why we have jobs as doctors and why we undertake to study medicine. So, with all of those things being said, let's get ready to dive into the respiratory system examination. So, the Bible talks about when God created the first man, Adam, he breathed life into him. This idea of breath, this idea of breath being the essence of life is really, really important. And we get it. We get it because the lungs are these powerful organs at the middle of our body that determine whether we can carry on cellular respiration or not by bringing in oxygen, by getting rid of carbon dioxide. But we don't look at the lungs themselves when we do respiratory examination. We look at the body, the chest, principally. And so we do want to remember what's beneath the surface because that's what we're actually trying to examine. So you have the lungs, you have the right and the left. Obviously, on the right side, you have 3 lobes. Okay. On the left side over here, you have 2 lobes. So the right side, you have the upper and middle and lower, and on the left side, you have just the upper and lower. If you look at this right-handed picture, you see that the right upper lobe is more anterior, the right lower lobe is more posterior, and then the right middle lobe is below the right upper lobe and typically is examined in the mid-axillary line at about the 1, 2, 3, 4, 5th interspace, right? So remember these things. And also that the diaphragm is right below the lungs and the liver beneath that. And so sometimes you get effects of the abdominal cavity pushing up onto the lungs. Okay. So, as you guys know, when we do physical examination, we in general do 4 things. We inspect, we palpate, we percuss, we auscultate. And these are big fancy words to remind us of what we're supposed to do in physical examination so that we don't forget anything. As you guys know, we won't be doing all 4 steps on every single patient that we see, on every single examination we perform on a system, but we keep them in mind so that we do not forget anything. So, with that in mind, let's talk about inspection. What can we see? How can we use our eyes to examine the patient? So, we start, of course, with general inspection. That begins as soon as you lay eyes onto the patient before you formally start your examination of the respiratory system. But you can learn a lot from that view from across the room. You can note whether there's breathlessness or not. How fast is the respiratory rate? A normal respiratory rate is probably between 12 and 15 breaths per minute. Anything beyond, 25 is certainly abnormal. Probably anything, honestly, 20 and beyond for an adult is certainly abnormal. For babies, it's much higher because they have a much higher metabolic rate. But in an adult, we're thinking in that 12 to 15 range for normal. Anything more is too much. Anything less is too little. The work of breathing, not just how fast are they breathing, but how hard are they having to work to do it. Are they able to breathe comfortably without visible effort, or are they using accessory muscles? Are they utilizing a tripod position? That's bracing themselves with two arms on the table in front of them to provide a structure off which their chest can pull to breathe. Are they pursing their lips? That's enabling them to maintain some positive end expiratory pressure. In other words, it's enabling them to keep their airways from collapsing, typically when there's obstruction in the lungs. Are they using paradoxical abdominal movements? In other words, is their abdomen going inward with inspiration? That is abnormal. That should not happen. It signifies an increased work of breathing. And again, not just the rate, not just the effort, but also the pattern. There's so-called Cheyne-Stokes respiration, where someone is breathing slowly and then faster and then faster and faster, then slowly, slower, slower, slower. And they might actually pause and stop breathing for a stretch. This is highly abnormal, very pathological, signifies neurologic problems in most cases. There's Kussmaul respiration, where, say, a person with diabetes and ketoacidosis is trying to breathe off acid because they're acidotic. Therefore, they are taking these deep, sighing respirations. And there's even the smell of that. You may smell ketones, in other words, a fruity aroma on their breath because of that. There's, of course, additional breath sounds, noises with respiration. Normally, breathing is very quiet, but you may hear something like stridor, which sounds like this. And it may be accompanied with a cough we might call a croupy cough that sounds a little bit like the barking of a seal, like okay? So those things signify upper airway obstruction. It's an inspiratory breathing noise. In other words, it happens on inspiration. Loud, noisy breathing on inspiration signifies a problem with flow above the thoracic inlet, in other words, in the throat. Wheezing is from the lungs, from the smaller airways, and it's a musical noise. And of course, if it's significant, you may hear wheezing without putting the stethoscope on the patient, though most of the time we detect wheezing, we will detect it with the stethoscope. And then obviously, if obstruction increases a lot, there isn't enough air movement to cause wheezing. Those people are very, very ill. They aren't wheezing because the obstruction is so bad. So wheezing is a significant sound you may hear. We note other things about the patient, their general status. Have they lost weight? In other words, is this consistent with lung cancer? End-stage chronic obstructive pulmonary disease or emphysema will give you weight loss. Chronic bronchitis, typically associated with weight gain and fluid retention. So you want to make note of their weight and their mental status. Are they anxious because they're hungry for air that they can't get? In other words, sort of hypervigilant and alert. Are they sleepy because of accumulating carbon dioxide in their system that's making them tend towards sleepiness and eventually towards being comatose if it's not corrected? So mental state does matter as well. Make note of all these things. Other things you may note. Of course, their other vital signs are important. Their blood pressure and their pulse. You know, if the lungs become hyperexpanded enough, you might get hypotension because the heart can't fill and push blood forward. Or if there's a pneumothorax, in other words, lung tissue collapsed under the pressure of air outside the lung tissue inside the chest and putting pressure on the heart, a so-called tension pneumothorax that results in a drop in blood pressure. With this, you will often get what's called a pulsus paradoxus, which means that on inspiration, the blood pressure falls by more than 10 millimeters of mercury, again, because of the pressure of extra air in the chest cavity that's causing tension on the mediastinum and the heart. You want to look at the mouth and the tongue, of course. You know, somebody with cyanosis, central cyanosis, which is going to be associated with respiratory failure, hypercapnic respiratory failure, and hypoxia. These people tend to have a blue or purplish tint to their lips and their tongue and their mouth. You want to look at the skin and the hair and the nails. You know, do you see evidence of erythema nodosum, which I have pictures of coming up? Just red nodular abnormalities of the shins, typically associated with sarcoidosis, a lung disease. Are there skin manifestations of cancer, which we have another picture of coming up? Are there discolorations of the hands and fingers and nails from tar because they're smoking chronically? Look at the hands. Do that examination for clubbing we taught you in the first semester. Have them do the test looking at Shamroth's window to see if it's there. If it's gone, they have clubbing, and you might want to measure that more carefully. Do you see tremor? Do you see asterixis? And that's when you have them flex their hands backwards like they're trying to stop traffic, and they flap downward because their mental state is impaired. In respiratory disease, that's because the carbon dioxide levels are so high, they can't stay awake enough to hold their hand in flexion, so they flap downward, up and down, up and down. You look for vascular evidence of problems in the chest, so jugular venous pressure being elevated, you seeing distension of the jugular veins in the neck can indicate a heart problem like heart failure, but can also be the result of extra pressure put on the heart from the other structures in the chest cavity, particularly if there's air outside the lung, a pneumothorax, and that is putting tension and pressure on the heart so that it cannot fill fully. And of course, look at the lymph nodes, especially of the head and neck. As we taught you that examination first semester, we want to look for pathological lymph nodes, which might be associated with lung cancer that's metastatic, especially this Virchow's node or Virchow's node in the supraclavicular area on the left. Look for lymph nodes. Could be associated with tuberculosis, though again that tends to be not necessarily associated with tuberculosis of the lungs, but look at the lymph nodes. And here's some examination findings that represent what we just talked about. The lower left here, let me go back, sorry. Shows you evidence of elevated jugular venous pressure. Those jugular veins are very distended. The tongue is showing you what the discoloration of central cyanosis looks like. The nodule of the skin here, third from the left, is showing you a cutaneous or a skin manifestation of lung cancer. And then the last picture is of erythema nodosum of the lower leg. So when we actually get to the respiratory system, what does inspection look like? So the first thing, how do you do it? You position the patient properly. We'll have them seated, very often reclined to 30 to 45 degrees with the head of the bed put back slightly like that. I follow a uniform sequence because, again, I don't want to leave out any area of the lung. So I tend to go from back to front. I also go from top to bottom and side to side. So as I examine, I will start on the right upper, and then I'll go across the left upper, and then I go down one on the left, and I go across to the right, and then I go down on the right, and then go across to the left, and I just work from top to bottom and side to side, and from back to front or front to back. It really doesn't matter. Just do it in a systematic way so that you don't forget anything, and then always remember to listen in the right mid-axillary line, to listen to the right middle lobe, or to percuss over the right middle lobe. You don't want to forget that third lobe on the right. So what are we looking at on inspection of the chest? We're looking at the skin. Are there rashes? Is there visible blood vessels from increased vascular pressure? Are there scars from a previous operation like a lobectomy that was performed for lung cancer or for particularly bad lung infection, something like that? We also inspect the chest wall. We're looking at its diameter. You know, the normal chest wall is going to be wider from side to side, left to right, than it is from front to back. So the so-called lateral diameter is usually wider than the antero or front to posterior back diameter. So if the AP diameter is increased, it's what we call somebody being barrel-chested. It's just they're more round in terms of the circumferential look at their chest. That's to go along with hyperinflation of the lungs typically. Think of the patient with chronic obstructive pulmonary disease, emphysema, that has a barrel chest. Other things about the chest wall, kyphoscoliosis, so abnormal bends and curvatures of the spine can restrict lung movement and prevent full filling of the lungs. You can get pectus carinatum, which is a pointing outward of the ribs in the front, like a bird's beak, we say. And then you can also get pectus excavatum. So excavating is like digging a hole. So these people appear to have a hole in the chest wall in the front. It's covered with skin, of course, but this pushing inward of the rib cage may restrict lung movement. In some cases, this has to be corrected. So again, just make note of the skin and the shape of the chest and the structures of the chest wall as you inspect the patient. So after inspection, we move to palpation. We're going to use our sense of touch to augment or to add to what we detected with our sense of sight. So palpation, what do we feel? How do we go about this? So there are a few things you're going to want to feel. One, you're going to want to use your sense of touch to help determine the position of the mediastinum. In other words, the heart, the great vessels, the trachea. Are they where they are supposed to be? If they are, we worry little about that. When they aren't, that is definitely pathological, and we want to make note of that and determine why. So, how do we do that? First thing, and there's a video coming up that'll give you an example of how to go about this, but first thing, we want to palpate the trachea. So we're using our fingers of the right hand to go into the suprasternal notch and feel the position of the trachea. It should be in the midline. Should be in the midline, okay? If it's not, if it's shifted to one side or the other, maybe something in the chest is pushing the structures over, like a tension pneumothorax where air has accumulated outside the lung on one side and is pushing structures to the other side. Or it may be something pulling, like collapse of a lung, and that may be pulling structures to one side or the other. At any rate, you have to figure out why it's moved, if it's moved. So we feel the trachea. We also go and feel the cardiac apex beat. It should be in the midclavicular line in the fifth intercostal space. If it's not there again, that may signify the mediastinum is not where it's supposed to be, because the apex beat should not be shifted left to right. It should be right there in that midclavicular line in the fifth interspace. We'll also lay our hands on the left side of the chest. This is a little bit paradoxical to think about, but we're looking for a right ventricular heave. Well, as we know, because of embryology and how things form, the heart turns inside the chest, and so the right ventricle isn't actually located on the right. And as such, when we go to feel for a right ventricular heave, we're going to feel just left of the sternum with our right hand placed flat on the chest wall. And what we're looking for at that point is for pulmonary hypertension. When the blood pressure in the lungs is elevated, it should be a very low pressure system, but when it's not, it puts strain on the relatively weak muscles of the right ventricle, and we get a heaving of that muscle that pushes everything forward on that left side of the chest. We also want to feel for chest expansion by placing our hands on the chest, and this will be more clearly demonstrated in the video. And then lastly, we palpate the skin of the chest wall and the neck, feeling for air under the skin, so-called subcutaneous emphysema. This tends to happen with obstructive lung processes, like somebody with a bad asthma attack or a severe COPD patient, or maybe trauma where you get leak of air into the subcutaneous tissues, or maybe people who inhale very deeply when smoking marijuana is something I've seen before in the States. But at any rate, you have this crackling like the crunching of fresh fallen snow as you push in on the skin, and that's because of air bubbles under the superficial layers of the skin. Now we're going to view a video that demonstrates some of these palpation techniques. Hopefully that'll make it a little bit easier for you to go ahead and put them into practice when you get to the lab. I'm indebted for that video to Geeky Medics. You can find them at geekymedics.com. And I apologize for the relatively poor video quality. Of course, you can get the actual video on YouTube or from their website, again, geekymedics.com, and view it with better quality. But just to give you an example of what it looks like to do palpation of the chest. So other things you want to feel when you're examining the chest, you want to examine the ribs. The rib cage are, of course, a major part of the chest wall. And you want to look for costochondritis. That's inflammation at the joint between the ribs and the sternum, the breastbone. And you typically can reproduce this by pushing directly on those areas. So a very common cause of chest pain is inflammation in this area. And you know, we take chest pain very seriously because it can signify, of course, things like pulmonary embolism, acute myocardial infarction. But this tends to be a sharp pain, and you can reproduce it with direct pressure, and so we typically don't do a massive workup on these people. We give them some ibuprofen or something like that. To examine for fracture, you want to just feel along the ribs, and of course you're going to be guided by the patient's pain as to where to feel. And then often we will apply pressure, putting our hand over the breastbone and over the spine in the back, and then providing some front to back pressure, some anteroposterior pressure. That pressure will tend to reproduce pain at the site of a fracture of the ribs. And then you can also get pain in those areas from pulmonary infarction. So when the blood flow to the lung tissue itself is cut off, again, that won't give you any palpable pain. So that's a deeper issue. So we're always thinking also not just, you know, front to back, top to bottom, side to side. We're also thinking about superficial to deeper. We're starting with the skin, then we're going to the subcutaneous tissues, then we're going to the bones and muscles, then we're going to the pleural layer beneath them, then we're going to the lungs beneath them. So just think about the progression we're following here. Okay, so percussion. We're going to listen for what sound things make when we tap on things. And so we'll view a video on this as well very shortly. But the idea is determining if something has an air density. You know, the lungs should have an air density, a very hollow sound when you tap and perform percussion. Whereas if you have fluid filling the lungs, then when you tap it will be dull sounding. If there's fluid surrounding the lung and putting a barrier between your hands outside the body and the lung tissue, then it will sound dull. If the lung tissue is collapsed and there's air surrounding the lung, that will be more hyperresonant. And so you'll get a very, very hollow sound happening. So, what sound does it make? Oops, hold on, let's go back, sorry. To percussion. So again, we're going to follow this progression. You guys recognize the procedure of percussion. It's demonstrated there on the left from McLeod's. And then where are we going to percuss? All these areas marked with red lines. Again, we're going front to back or back to front. We're going top to bottom, and we're going side to side, percussing over each area of the lung to listen for normal resonance, hyperresonance, or hyporesonance. In other words, dullness to percussion. And here's that video, again from Geeky Medics. And of course, all of these things demonstrated in the videos you're going to perform on the front and the back. We're only demonstrating the front, but of course, you're going to look for chest expansion over the posterior area as well. Of course, you're going to percuss in the posterior areas as well. So what does it tell you? Again, just to review what I've already said, more or less, there's a chart from McLeod's that you can look back at in the text if you want. But, you know, normal lung will be resonant like air. But if it's hyperresonant, and you'll get a feel for what that sounds like as you do more and more pulmonary examinations,
that's consistent with pneumothorax. So air around the lung, putting pressure on the lungs. If you get dullness, that's consistent with pulmonary consolidation or pulmonary collapse. In other words, that lung tissue that's all dense and together without air in it will give you that dullness. Or in cases of severe pulmonary fibrosis, scarring of the lungs. And then lastly, stony dull. It's hard to know how to describe that to you exactly, but that's going to be when you have fluid outside the lung. So fluid between your tapping finger and the lung tissue with air in it. And one form of pleural effusion can be blood. So say if you have a hemothorax, blood in the chest instead of some other fluid in the chest, that will give you the same resonance to percussion. So then we move on to auscultation. And honestly, if you ask people about the examination of the lung, this is probably primarily what they're going to be thinking about. But as we've already seen, there's a lot more to the examination than this. Nonetheless, this is very, very important to add to what you've already learned by looking generally, looking more specifically at the chest, feeling the chest, and tapping on the chest. So auscultation, what will you be hearing? So how do you do it? First thing, you want the patient relaxed, and really ideally they'd be breathing deeply through the mouth. Just be careful not to proceed too fast and to make them hyperventilate, because then they can get dizzy and feel nauseous and faint and all of these things. So just proceed slowly and carefully. You want them breathing comfortably, but through the mouth, just to get plenty of air movement to generate sound. Again, we're going to go side to side. We're going to compare the subclavicular or infraclavicular area on one side to the infraclavicular area on the other side. We're going to compare the parasternal area on one side to the parasternal area on the other side. And that will help you detect abnormalities. When they both sound the same, odds are you're hearing normal on both sides. When there's a difference, then you want to pay more attention to that difference and decide which side is abnormal. We listen anteriorly from above the clavicle down to the sixth rib. In the lateral areas, we listen from the axilla down to the eighth rib, and this especially applies to the right side where you have the right middle lobe around the fifth rib, fifth interspace. And then posteriorly, you're going to start right, again, up near where the clavicle is, but behind the trapezius muscle, and then go all the way down to the 11th rib. And what are you going to listen for? You're going to listen for the quality and the amplitude of breath sounds. Are they vesicular, which is normal? That's normal respiration. Are they bronchial, which is louder, more rough sounding breath sounds? If you want to know what that sounds like, you place your stethoscope over the trachea or in the very, very most superior part of the chest, right below the the suprasternal notch, and that'll give you an idea for what bronchial sounds sounds like. If you're hearing that in the lower lung fields, that's abnormal. You're listening for gaps in inspiration and expiration. And you'll notice I mentioned the I to E ratio, the inspiration to expiration ratio. If you look at the top of that diagram over there, you see vesicular breath sounds, and you can see that inspiration is longer than expiration and louder slightly, and expiration tapers off near the end. The bottom is a representation of bronchial breath sounds, and again, you have a gap between inspiration and expiration. 1, 2, expiration is much longer as far as a sound goes. Or if a patient has got obstruction, like wheezing in asthma or just airflow obstruction in COPD, the expiratory phase will be much longer. So typically, inspiration is about twice as long as expiration. If they're equal, or if expiration is longer, that's very abnormal. And if the sounds are decreased in an area, go ahead and have the patient cough. See if that clears. Sometimes you get a plug of mucus that will prevent you from hearing sounds in an area. Very often, If you have the patient cough, it will clear and you'll be able to hear normally in that area. If not, maybe you have an abnormality. Maybe there is pneumonia or something like that. You want to have a listen further. Okay. Other maneuvers we're going to do as we're listening. So first of all, we're listening for the quality of the breath sounds and inspiration and expiration. Are they normal and all of these things? And then we're going to have the patient say 111 in each area. We're also going to have the patient whisper 111. So they'll say 111, you'll listen. Do this on both sides in an area, especially if you hear an abnormality in the breathing, either decreased sounds or increased sounds. You'll want to have them do this. When they whisper 111, you shouldn't hear that in normal lungs. The air is not transmitting the sound very well, and so you'll hear when they speak it, but you won't hear it when they whisper it. If you do hear the whisper, then that is an increased transmission of sound. That goes along with consolidation. In other words, there's fluid inside the lung, like pneumonia would give you, and that is increasing the transmission of sound to your stethoscope. So what are some other things you can hear on auscultation? Extra sounds. You can hear crackles. This occurs from the opening of collapsed peripheral airways on inspiration. So say you have pulmonary edema and that fluid is putting pressure on the small airways and they're collapsed down. When you take a deep breath in, as they pop open, they will make a sound like crackling, like a small little popping or crackling. We've already talked about wheezing. It's musical. It happens in expiration, and it comes from airway narrowing. Turbulent flow through narrowed airways. And then there's also the sound of a pleural friction rub, and this gives you the sound a crunch like treading on fresh snow. And it happens typically from inflammation that leads to some scarring and abnormality, not scarring, but stickiness, I should say, of the pleural lining. So because the pleural lining is sticking to each other, as you breathe in and out and the chest wall moves, it's popping that open and it's giving you that friction rub, that crunching sound. So it could be from something like vasculitis, say lupus, causing inflammation in that space. And it could be something like pneumonia, which is giving you fluid around the lung, a so-called parapneumonic effusion. That will be very inflamed and might cause stickiness and crackling. Typically, if you have them breathe in deeply, you'll hear it best at the end of that. The chart on the right talks about the various sounds you may hear in inspiration. So when you hear early inspiratory sounds, we're talking about small airways disease like a viral infection leading to bronchiolitis. If it's middle of inspiration, you're talking more like pulmonary edema. And then late phase of inspiration, you will hear the fine crackles of pulmonary fibrosis. You'll hear the a little bit louder, more coarse sounds of pulmonary edema maybe. Or just, again, these bronchial secretions, mucus plugging and COPD, pneumonia, lung abscess, tuberculosis, that kind of thing. And then if you're hearing it in both inspiration and expiration, we're thinking about the coarse sounds of bronchiectasis. In other words, destruction of the lung tissue from chronic inflammation, like you get in COPD or cystic fibrosis or something like that. And again, don't focus on the abnormalities. I really want you to focus on the normal process of examination. I'm just giving you examples of the kind of things you're listening for. Primarily what you want to be able to do at the end of this lecture, this course, CS-2, is to be able to conduct a normal respiratory examination. So primarily you're going to be listening for the sounds of normal respiration. If you don't hear them, you want to be able to know normal well enough that you can say, that's abnormal. And really defining that abnormal will come later with more practice and more examination time on your clinical rotations. But this is just to give you an idea of the kinds of things we listen for. Once we focus in on inspiration and expiration and how they sound and comparing it side to side, we can listen for some of these extra sounds. We can better describe or define what we're hearing if we know what some of these other things are. Okay, so we want to go ahead and, of course, pull it all together, right? We've given you a lot of details. But when you get to the wards, you're going to be taking a history, you're going to be doing a physical examination, and then you're going to have to present that physical examination to someone more senior than you, maybe a junior doctor, maybe a senior doctor, and you want to be able to put it all together. So first of all, from McLeod's, to help you, this is the normal process of examination. So really, I want you to know these steps really, really well. We've broken them down today into inspection, palpation, percussion, auscultation, but just know what to do, what to look for, how to do this basic examination. This is very, very important. Breathing is important. So know this one well. You'll do this on nearly every patient you see, probably. So this is the sequence. And I don't have to go over it again. We just went through the whole thing, obviously, through the lecture. This is just to remind you that this chart is here for you to look at, but it's also located in the respiratory chapter of McLeod's. And it is a really good thing to study when it comes to the OSCE and when it comes to actually being able to perform these examinations in the hospital. So now what we're going to see is an example of someone presenting their findings. And in the end, this is what you want to be able to do. You're gathering all of this data and you're going to put it together to make a diagnosis for the patient. And especially when you're a student, really you're putting it together so that you can communicate it accurately and effectively to someone else who's going to be helping you come to a diagnosis and make decisions for the patient. So you always want to be able to take all of these findings and communicate them back to the patient about what your findings were, communicate them to your colleagues about what your findings were, and to have them in your own mind and to document them so that you can support the diagnoses that you're considering. So let's watch another video from Geeky Medics about how we put this all together at the end in terms of presenting our findings.
In summary, I saw Dan, a young male, who from the end of the bed was comfortable and not short of breath. There was no peripheral stigmata of respiratory disease. There was no evidence of a tremor. On palpation there was symmetrical chest expansion, and on percussion the chest was normal resonance. On auscultation there was bilateral air entry with no added sounds. This is a normal respiratory examination.
There you go. So in sum, want you to know the normal respiratory examination really, really well. That looks like first getting a good history before you enter into the examination. That's going to point you towards, hey, I need to do a respiratory examination. After that, you're going to make note of your general inspection. What's generally overall going on with the patient? What's their color like? What's their comfort level like? What's their breathing like? What's their posture like? What's their level of consciousness like? Then you move into inspection of the chest itself, as we talked about. Once you've done the inspection of all of the structures of the chest, in terms of what they look like and how they move and that kind of thing, then you move into palpation. And you want to, again, make sure you know where the mediastinum is, and you know the chest is expanding normally on both sides. There are other skills we didn't cover that you may want to know about in the future, like examining for tactile fremitus. In other words, increased transmission of vibrations of sound to your hands as you touch the patient when they talk, like saying 99 or 111, so that you get a sense of increased sound transmission like you have with pneumonia or something like that. Anyway, you're going to do the general things: inspection, palpation. You're going to go to percussion, where you're going to tap out top to bottom, side to side, front and back of the patient to see if you hear any abnormal resonance, sound coming back to you as you tap. And then lastly, you move to auscultation with the stethoscope, where you're going to listen with the diaphragm of the stethoscope over every lung field anteriorly, laterally, and posteriorly. And in the end, you're going to think about, what did I find? And you're going to describe all that you found to a colleague or back to the patient, so that as you explain to them the diagnosis or the diagnoses you're considering, they'll understand why you think that. And your colleagues will understand why you think that and will be able to participate with you in the care of the patient. So that's it. That is the end. Thank you all very, very much for listening. Hope it was beneficial. Obviously, feel free to email me with any comments or feedback you have about the videos. My email is Joel, Joelv. So my name is Joel Vaughan. So my email is Joel, Joelv, at hu.edu.jo. And I look forward to seeing all of you in the lab to practice these skills. Thank you.